Hi, my name is Harriet Snowden and I'm the Patient Experience Lead for the East of England Ambulance Service. Both myself and the Patient and Public Involvement team have been busy co-producing our Patient and Public Involvement Strategy. And this is a really exciting time for the Trust to be able to work with our patients to understand exactly what it is that we should be doing to engage with our communities, work with our patients, and give us direction for patient and public involvement moving forwards over the next 2 years. Co-production isn't just another buzzword. We've enjoyed working really closely with our communities and specialist groups to ensure that everybody's voice has been heard. This involved working together through several sessions, understanding what our patients told us, ensuring that all of this was captured. And our patients developed this with us, even down to the wording on our final strategy on a page. And this is how we ensured that our patients' voices were all captured. We ensured that all of our localities were represented. We had 70 attendees across 16 sessions. And we held sessions for specialist groups, including young people, patients with mental illness, and patients with learning disabilities, alongside open forums that we had with our local communities. We had representation from our volunteers, our community engagement group members, and other local partners. And all of this enabled us to have a well-rounded view of what it was that our patients were telling us. Together, we completed a thematic review and we sense-checked this with our patients. And this has built the very foundations of our strategy. So what does this all mean? So we learned that we need to work with more accessibility and that the Trust will review and implement new ways to engage with people in an accessible way, considering how our patients are enabled to become involved. We talked about the importance of networking with other local groups and organisations that our patients access in their communities, and that we will work with our teams, staff and volunteers to engage with a wider range of patient groups, their representatives and organisations in the communities that we serve. We discussed the importance of communication and that the Trust will use the ideas gained during our co-production to develop a multimedia approach to sharing and promoting involvement and engagement. Involvement and engagement is the core of everything that we do as a team. The Trust will plan and work with our staff and volunteers to offer a greater variety of engagement and involvement opportunities, including co-production, projects and events. Ethos and the approach that we take as a Trust is important to our patients. And we agreed that we'll engage with people compassionately, giving honest information about the Trust and using our patients' voices to support quality improvements. And it's throughout this co-production of our strategy that we've been given a really clear direction as to what we need to achieve, how that is expected to be achieved, and ultimately how we ensure that our patients' voices are incorporated into the work that we do as a Trust. And on that note, that's enough from me. So let's hear what some of our patients have to say about the co-production process and the strategy that we developed.
The sessions were all online. It was led from either the floor or Harriet. It was easy to get by. Everybody was listened to, and it was decided at a very early stage to make it as simple as possible, to make it a one-page strategy so that people could understand it understand it very easily. The sessions were interactive from both sides. It wasn't a one-way conversation. Everybody's points of view and thoughts and the processes were listened to, and a lot of them were actually implemented. There was a lot of people with a lot of experience who had input into the process, and everybody that participated who had anything to add, it was added into the process. I was involved in at least one of the sessions for the wording on a page, where each one of the 5 areas of the strategy were looked at in depth to get the wording right and get the message across. There was a lot of input from the floor, from the participants, and the strategy, when worked out, was as everybody wanted. I think that with all of the sessions that were held, the 17 sessions with different people from different areas of E-East, a lot of experience was put into it, and I think the whole process was very easy. And once it had completed, I think it's a complete session. It was from the one of the sessions that we had towards the end that I actually heard about the community engagement group as part of E-East, which I looked into at that time. Coming from a non-NHS background, I felt rather privileged that I was invited to and accepted into the process, both in BLMK and E-East, and that when I was involved in the process, even though I didn't have the NHS or medical background, that my thoughts and input was appreciated and entered into the process. So as I say, I felt privileged that that happened. I think that the process, once it gets up and running properly, will be for the benefit of the whole community.
Since 2012, I've become increasingly involved in being the patient voice. Since 2003, I was disabled and unemployable, but I had the opportunity in 2012 to participate in the research conversation, and that has grown. And I had an email from the Citizen Senate inviting me to be part and parcel of this particular project. And it appealed to me because I became, my route to disability and hospital was via the ambulance service. And I had a sort of particular things to say. There are things about my experience that were particularly good, and there are things about my experience that were particularly bad. And I know from what other people have told me that the quality of things can fluctuate. So having had all this experience in representing the patient voice at all stages of different conversations with different trusts, different organizations, I felt I had a contribution to make. The meetings were quite a large number of contributors, all of whom had different perspectives, different stories, different reasons why they were there. There are people who had no disabilities. There are people there who had their own disabilities and their own problems. And there are people there who cared for other people. So it was very, very representative of the public. And throughout the meetings, there was every opportunity for people to make their own individual contribution. The meetings were steered and guided very, very well, so there wasn't a lot of time wasted on peripheral matters. And the agenda was such that we had to cover specific points, and all through that process, these points were very well covered. And as I said, everybody who participated in this conversation had the opportunity to make their views known. And it was really, really interesting because we sort of started with a blank sheet. We know where we are. We know where we think we know where we want to be. We're not quite certain of the journey, and we're not quite certain of exactly where we want to be. So that was very, very encouraging, because so often in these meetings, you turn up to a screen full of people, and the people who are running the meeting, they've got a very fixed idea of what it is they want the conclusion to be, and everybody's guided to that end. But this particular project, that wasn't the case. You knew roughly where you wanted to be, but you weren't quite certain of exactly how it would look and how it would get there. And that was where we came in, because you listened very carefully to us, and you were very open. And there was evolution. There's an evolution of the process of thinking. So we started where we all were. We knew roughly the sort of, you set us questions as to where it is that you want answers. And the way that the meetings ran over a period of time, those different answers gave you different perspectives and changed your agenda. Not the complete agenda as to where you wanted to be or the questions you want to answer, but how we got there and how the strategy eventually looked was very different from, I think, from what you anticipated it would look like from the very beginning. Anyway, when it comes to the language, there are people who had particular concerns about the wording, and to some of us, those details were not particularly important, but to other people they were. And where wording was critical, that wording again was listened to, and you paid attention to the different nuances of what the wording meant to different people, because language is a very, very complicated thing, and that's why we have so many arguments and so many rows and indeed so many wars. Language so often gets in the way of communication. So you use the opportunity to take us through people's opinions about the language that was used and modify the final result. I have every confidence. I've got every sort of optimistic expectation that what we've come up, what we've designed, is going to work. There needs to be a period of evaluation, and we do need to come back together in about 18 months' time, I think, to assess have we traveled to the point where we wanted to? Has this strategy been effective? Has this strategy contributed to what we needed to do? Member servers are involved in these conversations like this because they want to get it right for patients, and that gives me enormous optimism.
Both myself and the patient and public involvement team are really excited for our next steps. We're looking at how we can achieve this strategy. We've developed a really clear work plan and an implementation plan, recognising the importance of our volunteers and our staff in this. And we're looking forward to reaching out to our communities and our patients to ensure that their voices are heard and taken in by the trust when we're looking at quality improvement. So if you would like to get involved, then please contact our patient and public involvement team, who will be happy to hear from you. Thank you.